The topics we are going to discuss are the breathing, assessment of the breathing and the conditions which lead to the abnormal patterns of the breathing and required treatment, different ventilator strategies, and what are the newer modes of these ventilation strategies, and final conclusion. Breathing on observation, the patient respiratory rate, normal respiratory rate is around 12 to 20 breaths per minute. The bradypnea in trauma patients may be considered. It may be due to raised ICP or any chest wall injury seen as a part of the Cushing's reflex. And on other conditions, we may also consider opioid toxicity, which may lead to the suppression of the respiratory mechanism. Tachypnea in trauma patients may be due to chest injury, pneumothorax, or flail chest, or a direct airway injury such as the tracheobronchial injuries, or due to the rupture of the diaphragm, which further leads to the shock acidosis conditions. On general inspection, we may observe the increased work of breathing, such as using the accessory muscles, and we have to look for any visible injuries or the deformities of the chest wall. And the trachea should be palpated as it is in the central position, or it might get deviated in injuries. Chest wall assessment, flail chest. In flail chest, it is more than to fracture of the ribs at more than one place of the same rib. In flail chest, we can observe the paradoxical breathing, that is on inspiration, the chest wall is congested. Pneumothorax and tension pneumothorax, injury to the chest damages the lung tissue and allows the air into the chest cavity. And on percussion, we may observe the hyperresonant note in the pneumothorax and dull note on hemothorax. And on auscultation also, decreased breath sounds may be observed in the pneumothorax and hemothorax on the affected side. Lung trauma, direct injury to the lungs. These are the conditions: flail chest, pneumothorax, bronchopleural fistula, tracheobronchial rupture, pulmonary contusion, or the bony injury of the chest wall. And the secondary effects, it might be due to the long bone fractures, part embolism, acute respiratory distress syndrome, which is caused because of the sepsis, or the transfusion-related lung injuries, while we massively transfuse blood due to the hemorrhagic loss. And the interventions on oxygen therapy, 50 liters of oxygen via non-rebreathable mask, which we aim for the SpO2 levels greater than 94%. Unless and until the patient is a COPD patient, we maintain the saturation levels from 88 to 92%. And the tension pneumothorax, this can be done through the finger thoracostomy if there are no immediate resources available. And the borders of the site which we do the thoracostomy is the lateral border of the latissimus dorsi and the lateral border of the pectoralis major in between the axilla and the horizontal level of the nipple, the upper border of the fifth intercostal space. And a chest drain can be inserted subsequently. In the hemothorax, it is managed when the insert through the chest drain. Large volumes of the blood loss greater than 1.5 liters from the chest drain being considered a massive hemothorax, which might further requires a surgical intervention. We can see in tension pneumothorax, the tracheal deviation is towards the right side, the mediastinal shift towards the right. This is the hemothorax, in which on the left hemothorax. Open pneumothorax, and it is mainly observed in the penetrating chest injuries, which results in the pneumothorax. Acutely, this is managed by covering the wound with a sterile dressing. It is covered by the securely taped on the three sides. The open side, it creates a wall which allowing the air to exit, but not to enter into the chest cavity. Once the patient is stabilized, then we can introduce the ICD tube, and surgery may be considered later. In the flail chest, the increase of the work of breathing significantly and can often lead to the respiratory failure. Hence, early intubation and ventilation are sometimes required. And this is the technique to place the chest tube. We'll blindly open the chest at the fourth intercostal space, mid-axillary line, above the fifth intercostal space, and the chest tube is inserted and it is connected to the chest drainage bag. In the chest drainage bag, we normally maintain the pressure up to plus 2 mm of water pressure, such that when on inspiration, when the pressure exists more than that of the 2 mm, then the fluid will be going to the chest drain due to gravity. This is the flyal chest. Most of the flyal chest is maintained by adequate analgesia in the form of a thoracoepidural nerve blocks, paravertebral blocks, or the pleural catheter, and chest physiotherapy. Mechanical ventilation is only considered when the distress is more and pulmonary contusion is there, and the gas abnormalities, PO2 less than 60 mm of Hg and PCO2 greater than 60 mm of Hg. This is the paradoxical breathing pattern which we can observe. Tracheobronchial rupture, the patient mainly presents with the dyspnea, pneumomediastinum, and pneumothorax, which does not resolve even with the thoracostomy. Intubation of the airway management, which should be done in awake state, such as to provide the positive pressure and to prevent the alveolar rupture. Rupture below the carina requires a double lumen tube or univent blockers, and the Fogarty catheters have also been introduced to they are introduced to ventilate the lung isolation. I mean, individual lungs are isolated separately to protect the bronchial anastomosis. Because when one lung is injured, there might be a chance the other lung is also to be injured because of the inflammatory response of the body or due to secretions. So in this X-ray, this large arrow indicates that of the hemothorax, and the small arrow indicates a pneumomediastinum, and subcutaneous emphysema also can be seen. And in the pulmonary contusion, it leads because of the fibroelastic skeleton of the lung is injured, and it is not only the affected site is not only injured, but also the contralateral side has also been shown to be affected because of the inflammatory response of the due to the secretions which stays this in the lungs because of the injury. The intermittent positive pressure ventilation usually forms the cornerstone of the management, and the ventilatory goal in this situation we maintain with the lowest values as possible to prevent the further damage of the lung with the low FiO2 and the plateau pressures and tidal volume. The tidal volume should be maintained less than 6 ml per kg of ideal body weight, and the plateau pressure maintained less than 28 centimeters of water, and FiO2 preferably less than 0.6. When the FiO2 is requirement is less than 40%, then we can consider weaning of the patient. And the PEEP can be maximum maintained up to 14 to 16 centimeters of water in severely compromised patient. If more than this PEEP is required, then we might consider mechanical ventilation through intubation. And hypercapnia can be tolerated as long as the pH is above 7.2. In early stages, we prevent this hypercapnia as it might cause an increase in the intracranial pressure.
Normal.
Normal 5 to 6. This is the maximum allowed values on, and maybe if more than that is required, then we will consider mechanical ventilation. Abdominal trauma. In abdominal trauma, the patient may not be breathe properly, or he might be in distress because of the severe pain, which leads to the shallow breathing and non-clearance of the secretions, which further increase the chance of the pneumonia. This use of mechanical ventilation early in these patients has been shown to decrease the incidence of this pneumonia. However, mechanical ventilation longer than 5 days, it increases the risk of late onset of pneumonia. And epidural analgesia, it also helps to reduce the pain, and the breathing pattern might be increased and provide pain relief, as well as by decreasing the pro-inflammatory cytokines. In head trauma, the main culprit is injury to the brain. Head trauma patients usually require ventilatory support due to respiratory distress, which is secondary to impaired consciousness or decreased respiratory drive, chest injury or the ARDS. The main goal of ventilation in head injury patients is to keep the low PCO2, because when the PCO2 is higher, then it might be leads to further vasodilation and the intracranial pressure might be increased due to secondary to cerebral vasodilation. So the guidelines stated by the Brain Trauma Foundation suggests that the prophylactic hyperventilation to maintain the PaCO2 less than 25 mm of Hg. In the absence of intracranial hypertension, it is not recommended. Hyperventilation is only recommended as a temporizing measure for the reduction of the elevated ICP. And this hyperventilation, it should be avoided in the first 24 hours of the injury as it might further leads to decrease in the cerebral flow, which further leads to decreased cerebral venous drainage, and it increases the ICP. If hyperventilation is used, cerebral oxygen delivery should be monitored by this jugular oxygen saturation or the brain oxygen tension probe meters. So the recommended that the oxygen should be maintained, monitored, and hypoxia should be avoided. PaO2 less than 60 mm of Hg or oxygen saturation less than 90% should be avoided. And average minute ventilation of 7.6 liters per minute and the PaCO2 of 35 centimeters should be suffice. Because when as we discussed earlier, when the PaCO2 levels is increased, it further leads to the cerebral vasodilation, which in turn increases the intracranial pressure. High PEEP was also avoided in these conditions at it may reduce the cerebral blood flow, which decreases the cerebral venous drainage. It increases the IC. To maintain this cerebral venous drainage, a head-up position of 30 degrees may be used, because due to gravity also the cerebral flow will be improved and the venous drainage will be increased, and it allows some blood flow to occur through the vertebral veins, as it is not affected by the PEEP. And different types of the ventilatory mechanisms we use in trauma patients. High frequency percussive ventilation. In this, the tidal volume is divided into many volumes, and it is delivered to the patient in many frequencies, which is around 200 to 300 breaths. Tracheal gas insufflation, that air is directly supplied to the trachea and to eliminate the PaCO2 levels. Low frequency positive pressure ventilation with extracorporeal removal of CO2. In this, the frequency of the ventilation is remained very low, 2 to 3 breaths per minute with this ECMO, and which further maintains the functional residual capacity of this lung. And in this pumpless assisted systems, we create a fissure between the artery and the vein, and the pressure gradient between the arterial system and the venous system itself allows the gaseous exchange. And prone positioning may be also be useful, but in recent studies, it showed that in prone position there is an increase in ICP levels, hence we'll further avoid in prone position. This is the high frequency percussive ventilations, in which the gas which we are providing, ventilation which we are providing to the patient, oscillations will be more. The frequency of the breaths will be more, around 200 to 300 breaths in low tidal volumes. In the tracheal gas insufflation, directly the ventilation is directly supported through the trachea, and the breaths are maintained in further eliminate the PaCO2 levels. In this pumpless systems, we'll create the fistula between the femoral artery and the femoral vein, and the natural gradient of the pressure gradient of the patient itself allows the gaseous exchange in this instrument. Ventilator strategies in burns patient. In burns patient, the airway is compromised mainly due to not only due to the facial traumas or the neck compromise of the airway, it may be due to the edema of the vocal cords and the lower part of the airway. Hence, we have to also consider mechanical ventilation early in this burns patient. And the another reason that is toxic to the patient is due to the damage to the capillary endothelium, which further causes the pulmonary edema and the bronchospasms. Considering mechanical ventilation in burns patient, it is also benefit to the patient as it also increases the fluid retention. As in burn patient, will be heavy fluid loss. And number of studies showed that this high frequency percussion ventilation in these patients, which helps in the early recovery of this patient. Special ventilation strategies. This is a single lung ventilation is primarily used for the containment of the harmful fluid secretions and blood because when one lung is injured and there are fluids and secretions in that lung, when there's a communication between the two lungs, it might damage the other lung also. Hence, we'll try to ventilate that lung separately. It can be achieved by a double lumen tube or a bronchial blocker. However, when the site of bleeding is unknown, then we might consider this double lumen tube to ventilate those both the lungs separately with different level of PEEP and different level of settings. This two lung isolated lung ventilations may be synchronous when the two lungs are ventilated at the same rate, or asynchronous when the rates are different. Here we can also use different modes of ventilation with different levels of PEEP to ventilate both the lungs separately. This is the right-sided double lumen tube and this is the left-sided double lumen tube. And this airway pressure release ventilation, this mode can be defined as a CPAP. It is a continuous positive airway pressure with intermittent brief release of pressure at regular intervals. That is when the pressure falls to the baseline pressure, the expiration takes place. Hence, the oxygenation, it is determined by the FiO2 levels, but the ventilation is determined by the difference between these two pressure gradients and the duration of the respiration and the spontaneous breathing of the patient. So when initiated for the first time, the CPAP levels should be equal to the P plateau of the patient when on conventional ventilator. That is when you're considering non-invasive mechanisms, and its duration should be kept as high as possible to prevent the alveolar de-recruitment, because when we are not ventilating the lung properly, the alveoli expansion might be, the capacity to expand might be decreased. Hence, before considering this ventilation, we have to consider the PEEP properly, such as all alveoli are gets open for the ventilation. To wean the patient from the APRV, the level of CPAP is decreased and its duration increased so that the number of air releases decreases. Shift to the conventional ventilation can be done once the CPAP has the plateau pressure has been reduced to less than 20 centimeters of water. Its duration increased 6s. That is the number of the pressure we consider is 6 and the FiO2 less than 0.4. It might also lead to the hemodynamical instability, since it is contraindicated in a non-spontaneous breathings, and it's also contraindicated in the severe obstructive disease patients, airway obstructive disease patients. And high frequency oscillatory ventilations. Here, the basic principle, it is maintained if it is considered only when the FiO2 requirement is greater than 70 and the PEEP levels is more than that of the 30 to maintain the adequate gaseous exchange. If the pH value is less than 7.5 and the tidal volume is more than 6 ml per kg and the P plateau is also greater than 30 centimeters of water, then we can consider this high frequency oscillator ventilation. It allows a piston which is attached to the diaphragm and it that is oscillated to deliver the fixed amount of small tidal volumes, that is 1 to 2 ml per kg and at a frequency of 3 to 10 hertz. The amplitude of this oscillation, that is usually around 60 to 90 centimeters of water at the upper airways. And the ventilation depends upon the pressure gradient in the upper airways, while the oxygenation depends upon the mean pressure in the lower airways and FiO2. In the mean pressure is usually more than 3 to 4 centimeters of water in the lower airways and of the lungs. And other newer modes which we consider as ventilation, newer modes for ventilation are closed loop ventilation, in which the computer, it is connected to the computer, which changes the FiO2 and the other ventilator parameters based on the patient's response. And this adaptive support ventilation was also, they uses a target expired volumes based on the patient body weight to adjust the ventilator parameters. In partial liquid ventilation, it is another strategy where we use this fluorocarbons instead of this gaseous mixture to ventilate the lungs. Because these fluorocarbons, they allow the free diffusions of the oxygen and carbon dioxide across the alveolar capillary membranes, and which also further provides the PEEP to maintain the alveoli open to prevent the atelectasis and prone position, but we consider it as a last option, as it said that it increases the ICP. And this further administration of the nitric oxide is also considered, as this nitric oxide leads to the vasodilation and maintains the ventilation perfusion ratios in the lungs, more in the lower lobe areas. The final conclusion of this mechanical ventilation in the trauma patients, as the cases of severe trauma are on the rise, it is important for us physicians to attend the trauma emergencies on the various aspects of respiratory supports in case of trauma. The protective lung ventilation forms the basis of the respiratory support in case of the chest trauma and the toxic injuries of the lung. Isolation of the lung becomes more important when lung is severely injured to prevent the further damage of the other lung and needs rest. The other is imperative to maintain the oxygenation of the body. The brain takes the upper hand when both the pulmonary and the head injuries are concomitantly present, because it might be due to the respiration suppression mechanism, which is because of the brain injury. So several newer modes of the ventilation have come up. They were introduced, which are based on the open lung concept. In this open lung concept, we maintain the alveoli open throughout the ventilation, but on the lower pressure sides, putting the lung through minimum possible stress, which still continues to use them for the oxygenation. Here we prevents the complete collapse of the air alveoli. And extracorporeal membranous oxygenation is the last resort, where the job of the ventilation is completely or partially taken over by the machine, which we will consider when all these mechanisms are failed. Not mentioned about the